A great honor to have here a distinguished director of the World Health Organization. It's already a tradition for these summits because last year we had virtually Dr. Hans Kluge, director of the regional office of the World Health Organization, which is based in Copenhagen. Dr. Kluge was here virtually for this summit. But in this case, now Dr. Stephen MacFeely from the WHO Global Organization, which is based in Geneva, in Switzerland. So it's really a great honor to have here the maximum responsible of data and analytics in the WHO organization. Is going to make an intervention now, and then followed by a distinguished speaker also from the European Commission that I will introduce later on. Steve, the floor is yours.
Thank you, Paul. Good afternoon, everybody. It's my great pleasure to be here. I hope you can understand, or at least I hope the translator can understand what I'm going to say. I have slides, so I hope I can get the slides up on the screen. So I've been asked to speak about a health data gold rush. So you'll notice the question mark. So I'm not making a statement, I'm asking a question. Does a health data gold rush exist? And if it does, what would that mean? We've seen an explosion of data around the world, and I'll talk a bit about that in a moment. And the real question is that data of any use to us? Can we do anything useful with it? And as we've heard in the previous session, that requires not only technology, but it also requires intellectual capital and human capital to harness those data. The other thing I want to talk about is also the kind of data in context. So they say generals always prepare for the last battle. And I think there's a danger too with statistics and with data that we're always preparing for the last pandemic, the last crisis. So at the moment we see globally a huge movement now across the world. People are setting up new preparedness kind of committees to learn lessons from the pandemic. And it's right that we do learn lessons, but the next pandemic or the next health crisis will be different. So what we have to do is develop data information systems that are flexible and adaptable, because almost certainly the next crisis will not be the same as COVID. And the data have to be adaptable enough and flexible enough that we can use those data. So let me start with a statistic. I guess if we think about a gold rush, we think about the massive growth in data. So this chart only begins in 2010. So we're only looking here at 15 years growth in data. And these are measured in zettabytes, and a zettabyte is a trillion bytes. So I began work in the National Statistics Office in Ireland in 1993. So like 1993 would be way off to the left on that chart. So in our lifetimes, the volume of data that exists have just completely changed. But as someone very wisely remarked, making the haystack bigger doesn't make it any easier to find the needle. And in fact, that's the challenge, because a lot of this is quite misleading. In a way, we look at the growth in data, so we see potential and we think, oh my goodness, with all of this data, we must be able to do this and this and this. But an awful lot of this data is noise. Every time we send a picture, we get a funny picture from our parents or our son, we send it to somebody else, we send it to somebody else. A huge amount of these data are just duplicate. They're just ridiculous kind of stuff. But nevertheless, there are nuggets in there that we have to learn how to harness. And this is really one of the big challenges facing us, is how to find the needle, how to find the pieces of gold in this ever-expanding universe of data. Now, I want to show you a global map. So this is a map. So at the moment, in fact, in about 10 days' time, the WHO will publish global statistics on excess mortality. This exercise comes out of data availability about mortality statistics. But I want to use it to make the point that even though the volumes of data are growing, they're not growing evenly across the world. So we see massive inequality. So if you look there, what you see straight away is in the middle is Africa, parts of Asia. Basically what that's telling us is we have really no idea what's going on regarding mortality. In the dark purple, which is really representing the wealthier parts of the world, we've got good mortality statistics. Not only the event, but we also know the cause of mortality in general. And then there's another huge swathe in green where we have partial information. So we have a reasonable idea about the volume of mortality, but the cause of mortality is still ambiguous, or it's only partial regions within the countries. So what you see is across the world, for one of the most basic health statistics, which is mortality and cause of mortality, we really don't know for about half of the world what's happening. And that's part of my job, is to estimate that. But I want to use this map because this is happening in Europe too. So maybe not mortality, but if you take more sophisticated statistics, there's still inequality so across the region. So even if you take Portugal, I'm sure if I knew enough about Portuguese statistics, that there's better and worse regions across the country where you have better and worse statistics. And not only in terms of existence, but also in terms of access. So there's no point in having data if you can't access it, and I'll talk about that in a moment. And there's really no point in having data if you don't know what to do with it either. So statistical and data literacy is important across the regions. Having the data is important, but also ensuring that there's access to the information. Now, one of the reasons that we've seen an explosion in volume of data is two things. One is the data revolution, if we can call it that, is inextricably linked to the digital revolution. So really over the last 20 years, we've seen a revolution in, we're all carrying one of these in our pocket, and these are just generating data second by second. But almost everything we do, the Internet of Things, we use social media. If you think about your health facilities, the amount of machinery in those facilities now that are all storing information. But also the concept of data itself has changed. So when I joined the Statistics Office in Ireland in '93, we really thought of data as just numbers, ones and zeros, and that's what we meant by data. But in fact, now the concept of data has changed utterly. Now we're talking about text, we're talking about images, we're talking about sound, and this has all come through digitization. That this wouldn't have been possible without the digital revolution. And this has had profound changes in not only how we think about data, but also the concept of data has changed as well, in that traditionally, at least as statisticians, we would have thought of data as raw material that we then process to produce statistics, which then is used to produce information. So data was only an input. But in fact, now from a geopolitical perspective, we now see that data is now a policy issue in and of itself. And in fact, in Europe, you see a whole swathe of new regulations coming out around artificial intelligence, around digital economy, around data privacy. And this is all data. I mean, if you're talking about artificial intelligence, you're talking about data. If you're talking about digitization, you're talking about data. So the whole concept of data has changed, and that has big implications for us. So what do we do then? So we're trying to organize a health information system, and we can distill health information systems down into two types. So there's primary and secondary. Primary are data that we collect ourselves deliberately to answer a question. So that could be a survey, a questionnaire. But in fact, most of the data that we're going to use in the future is going to be secondary data. So these are data that were not collected deliberately by us. They're data that are being generated by a machine, by some other system that we can use, but those data weren't collected for us. And the difference then is in primary data collection, you set out to answer the question that you want answered. So you ask the exact questions that you want answered. In secondary data, you're a price taker. You can't shape the data. You have to use what's there. So it doesn't necessarily answer the question that you want to answer. So it requires a bit more work. You'll have heard a lot of talk about big data. And like I said, big data, it doesn't mean large data. What big data means is large volumes of data that are highly unstable, that are changing quickly. And they're unstable because if you think of something like Facebook or an iPhone, every time they change the format on the phone, every time they change the visualization on a page, that alters the data, because we know color changes our perception of mood, the font size, all of these things impact on how we respond, and that will alter the data that we're then generating. So big data has huge potential, but it also has huge instabilities. Much more importantly, and the one that nobody really wants to talk about in the modern era, which is the one that's represented by all these bundles of pages, is what I would call administrative data. These are the data that are coming out of local and national government systems. Now, obviously, if they're on paper, they're useless. So the first thing we heard from the last session, data have to be digitized to make them useful. But we have to do a lot more with them too. We have to organize the information, and I'll talk a bit about that now in a moment. But administrative data really is the rich vein that we should be focusing on. This is the stuff that's coming out of hospital information systems, that's coming out of local government. It's not fancy. You've had these data for years, but I would argue you've never really capitalized on them. And largely because, one, you can't link the data together, and that's because they're not very well organized. And that's really the key of what I'm going to talk about. The other big, I think, opportunity is GIS, so geographic information systems, especially from a subnational or a regional perspective. One of the challenges with administrative data is that it tends to reflect the administration that it's in. So in a lot of countries, the health borders or health regions will be different to the police regions. They'll be different to the economic regions. But if you want to look at public health from a holistic perspective, you want to be able to look at health in the broadest context. And if the regions are different, then it's very hard to link the data together. And by geotagging information, that really allows you to develop what are called functional regions, which are much more meaningful, and it allows you then to overcome the challenges of different administrative boundaries. And this isn't very complicated to do, but it does require organization. You've heard the expression, I'm sure, data is the new gold, data is the new oil, the new fuel. So I don't agree, and I don't have time to get into why I don't agree, but I just want to use that analogy for a moment. So if you're the decision maker and you're thinking about oil, you kind of intuitively understand you need to extract the oil, you need to refine the oil, you need to store the oil, you need to move the oil. So you need to get it from out of the ground, you need to get it to cars, you need to get it to houses. And again, you intuitively understand that that means you need refineries, you need pipelines, you need containers, and all of those different pieces have to connect together in order to get the oil, which is crude and dirty, into refined petrol into the car. And you get that, you understand that. Where a lot of people struggle is if you think about data, you have to do exactly the same thing. Data on their own are absolutely useless. They're just there. So data, just like oil, that they have to be extracted, they have to be cleaned, they have to be refined, they have to be stored carefully. Just like oil, they're a precious commodity. There's a lot of confidentiality. So they have to be moved. So you have to get it from a statistics office, from a health facility, wherever the data is coming from, into the hands of the person who wants to use it. And you have to disseminate it. So data are like oil in that sense. They require infrastructure just as oil does, just as electricity does, just as Wi-Fi does. But it's a soft infrastructure, so people tend to think of it as kind of being invisible, that data exists and there you go, it's easy. It's not. Data systems require all the love and attention that every other system in the economy requires. So what I mean by infrastructure then in practical terms, so what does soft infrastructure look like? Well, up in the green box at the top, this is really about the governance piece. That you need legislation, so you need clarity around who's allowed to do what with your data. In Europe, you have GDPR, but that only addresses one aspect. That addresses the confidentiality or the privacy, but it doesn't address issues like ownership. It doesn't address issues around storage. So there's a lot of issues around, are you allowed to share data? So if you're a health facility and you want to link your data with another health facility, are you allowed to do that? Are you allowed to give it to the statistics office? Is the statistics office allowed to share it? So these are really, really fundamental questions. And without having the kind of legislative clarity, it really makes everything else extremely difficult. Then down in the orange box, which is really the core data infrastructure, this is the technical piece. This is very simple, but it requires, first and foremost, what we call single unique identifiers. So if I'm a patient and I go to the hospital, I should have one number, and that number should be used again and again so that you can see my health condition over time. But more broadly, I would argue that you shouldn't have a health number that's different to your national number, or at least they should be connected. Because in a moment, I'll talk about broader public health issues. And obviously, this is where the rubber hits the road, because this is where people get very touchy about security, about privacy. But if you want an efficient health information system, if you want an efficient government, then I would argue you're really going to have to decide where on the spectrum you stand between privacy and efficiency, because you can't have both. You're going to have to decide. It also means using international classifications. Instead of inventing your own classifications, adopt the international standards. So for example, in January, the WHO has just launched the new ICD-11, and I would encourage Portugal and all the regions to adopt that standard. And this is what allows data to move from one place to another and to connect like pieces of Lego in a useful way. And it's only then that you get power out of your data. Now, as well as having an individual number, you also have to have a location. So you need to use a common geospatial identifier. So that could be an XY coordinate if it's very specific. It could be some sort of a postcode or polygon number. It doesn't really matter as long as you're using the same number throughout your entire system. And these have to be common numbers. And then finally, there must be institutional coordination. One of the things I've noticed since I've come to WHO is actually how isolated health is from the rest of the kind of public administration. And to me, that's a real problem, because health data are useless in isolation, because as we've seen with the pandemic had implications for economy, for society. They've had implications, good and bad, for the environment. And we need to be thinking about health in that way. So unless you're connecting with other experts in other fields, so if you're preparing a preparedness committee, even if it's a health preparedness, and you don't have people from other parts of the broader society, from the economy, from the public sector, then you're not going to be prepared, because you're preparing, as I said, for the last battle, not the ones that are going to come in the future. As I said, the governance piece is critical. It's often a piece that people, they don't really want to deal with. They want to rush into the technical solutions. And I would argue that's a mistake. You need to spend time thinking about data governance, because if you don't, problems will follow very, very assuredly. Now, as I said, health information systems should not be isolated, especially if you're looking at the broader public health. Health is just another domain, but it affects the environment, but it's affected by the environment. People are affected by their educational status and how they view the world. As we've seen, health is massively impacted by the economy, but it also affected the economy, we've seen very clearly, and also society. I could add in a whole bunch of other bubbles. It doesn't really matter. I mean, you get the basic message. And if that's true, then you have to think of your informational systems in that perspective as well. You can't develop health information systems in isolation. You have to think about building your health information systems so they connect to the other parts of the economy, the other parts of society. So just to finish, the key word I would say is about integration. with all of the many new data sources available, whether it's big data, whether it's citizen science, whether it's primary data, it doesn't really matter. No one single data source will answer the questions that you want answered. So the real challenge is how to integrate different data sources, put them together so that you come up with meaningful information. And this is crucial. I mean, I can't stress enough, data on their own are really useless. Data are bits of information. You have to put them against concepts to produce statistics. And then in the value chain, what you're hoping then is people can use that information to generate knowledge. And that knowledge will hopefully inform decisions. So integration is the key, both on how to integrate different data sources and then how to integrate different domains of the economy, of society, so that they work together. Governance is crucial. It really is the first step to putting in place health information systems. Then you need to think about the technical infrastructure that you need. And then finally, when you get the results, especially at a regional conference, this is really important, is reconciliation. I worked for many years on the economic domain, and I've often seen regional models. And in fact, if you added up the different regional models, generally they tend to be worth about twice the size of the national economy, because every region wants to make themselves a bit bigger. You have to reconcile against the nationals, because otherwise your regional totals, they won't make any sense. They'll generally be out of context. So either you populate all the regions together, or you populate your regional statistics, but in the context of the nation, so that the results that you generate make sense. Because too often I've seen regions generating their own statistics in isolation, their own data, and they make no sense at all when you compare them then with wider aggregates. And with that, I'd like to thank you. Thank you.
So thank you so much, Steve, for this closing lecture of the morning. We have now already online here, and it's a great pleasure to welcome Boryana Spasova. She's a policy officer of the European Commission and in the DG Regio, responsible for regional development. It's really great to have you here, Boryana.
I'm a policy officer in DG Regio in the European Commission, and I have put together some slides to share with you our insights on EU level of what we have learned over time about effective EU investments in health. On this slide, you can see the policy I come from. I work for the cohesion policy, the so-called Politique de Cohésion. I hope I pronounced it correctly. This is the policy of the EU that focuses on the less developed and the transition regions, and is supporting them with a lot of structural funding in catching up effects. So you can see that the Canary Islands, the Azores, Madeira, together also with Portugal, parts of Spain, and most of Central and Eastern Europe, they are classified according to this policy as less developed, and because of that they receive quite a lot of money from the EU in different, for different priorities. What are these priorities? So they're structured around five policy areas, and here I'm not going to discuss too much about it, but just for you to know that under the more social Europe, specifically we focus in investing in equal access to healthcare. So there is a direct mentioning there on the importance of healthcare for all regional development. But in general, why do we invest in healthcare, and what is the role of the EU in all this? On the one hand, we see that across the EU regions, there are a lot of health inequalities. We get different levels of the quality of services, of medicine, the availability depending also on where you are situated, not only depending on the member state, but also depending on whether you're in the rural or urban areas, on an island, in a remote area, on the coast, and so on. At the same time, we're also facing public health risks, which tend to be also cross-border. And of course, we have the economic and social rationale in investing it to improve the labor productivity, the competitiveness and the growth, which will help the regions to catch up to the most developed regions in the EU. And at the same time, health is, economically speaking, also one of the most innovative and productive sectors in the EU, where a lot of people have their jobs, and also one that is producing a lot of GDP per capita, growth. Here, most specifically, the role of the EU and DG Regio is this territorial rationale, the territorial cohesion, which is just the importance of accessing the same type of healthcare, the same level of healthcare, and also having equal health outcomes in the different territorial entities, as I mentioned, in the different regions, in the cities, in the urban areas, in the islands, and so on. And the main purpose is, of course, to ensure equal access to quality healthcare services. But at the same time, the EU is supporting the member states in facing addressing some structural issues. So on the one hand, we know that there is pressure on healthcare systems, and now it's more and more the chronic diseases. But we also have aging societies, and of course, we are supporting the member states from the perspective of sustainability of public finances, of finding the most cost-benefit, cost-efficient measures and investments in order to improve more and more the health of our citizens. I'll start with just a couple of graphs that I find quite interesting. And this graph is not to tell you what is the total volume and how do we invest, but just to see over time, and that is just the last couple of years, how much more we have been investing in health in EU. This is just the cohesion fund, so the Rural Development Fund and the European Social Fund. However, you can see that since 2019, and of course that is also due to the pandemic, we have invested almost double the amount, reaching almost 24 billion of investments at EU level. And here it's important to say that it's not the EU dictating to the member states to invest, it is the member states deciding with the money that they have been allocated to invest in this specific sector. Another graph that I find quite relevant is the demographic change in the outermost regions, and also reminding the regions of what is coming in the next year. And this one only concerns, let's say now, the next 10 years. But we can already see here that the older population is growing older, and it's growing older in a faster pace than the shrinkage of the younger generation. So we see that for some regions, for example, Azores and Madeira, they're experiencing reduction of the population over the past decades. And then the population in the young population below 19 years will then be reduced faster than the population that will be increasing beyond 65%. And here it's also important to think about it in the bigger perspective. What would that mean? So for the investments in healthcare, it would mean that they will have to keep pace with the changing demands of different services to avoid either over provision or under provision of particular cares. If you think, for example, of how many obstetricians we'll need or gynecologists versus how much more, for example, long-term care for the elderly we will need and support with dementia and so on. But also this is important to consider from the perspective of how to invest in such a way that everyone has the same proximity to the next availability for care. And one last graph that just shows that public health is not cannot avoid the burden of what that faces some public administration issues. So here it's important to mention, maybe perhaps not as important for Spain and Portugal, but this is from very interesting barometer survey saying that quite a lot of the people have experienced corruption in healthcare, meaning that they have reported that in the last 12 months they were expected to give extra payment, a gift or a donation. And here you can see that here in the Eastern Europe, from where I am, we experience much more an issue with that. However, it is also worrying that these trends do not change over time, even on the EU average. So coming to the question, what are the key principles according to which we want to see our health systems improved? What should we prioritize? What are the priorities that the EU considers as important? Here, of course, as it was also already previously mentioned, the member states are in the lead of designing the healthcare policies, and the EU only has the role to coordinate, to ensure smart collaboration and to share the lessons. However, we already experienced quite a lot of push for more collaboration, for health union, and so on. But here, just some of the key principles. On the one hand, we encourage the member states to move away from hospital-centered models, which tend to be very expensive. The treatments staying in hospitals, it is very, very expensive. And to move to more personal-centered approach, including also considering the possibilities for home care, strengthening the primary health care, the facilities for general practitioners, for nurses, the provision of nurses, and then this shift from hospital-centered model to more community-based services to health promotion and disease prevention. As I mentioned, the emphasis is very strong on primary health care, shifting away from the hospital setting into a more community setting. And then the aim is also to achieve an integration of care between healthcare, social care, and long-term care, in the sense that we could do this also using IT systems, using digital health, and many, many more, but to ensure that it is overall the healthcare systems are designed to be more affordable, that the cost-benefit analysis is fine, or is good for us, and at the same time that we invest sufficiently in the digitization of health services, and that of course relates quite a lot to the presentation of Steve that we just heard. One of the biggest parts of the investments go in e-health, in telehealth, in public information systems, in ensuring that member states will be able to share important medical documentation and so on. And for that, we first need the infrastructure, but we also need the governance, and we need the collaboration between the member states. And not to forget that the health workforce. So here we need to address shortages. We need to ensure that the next generation of doctors, of nurses is sufficiently there, that we can attract enough people for these professions, and that they are trained the skills that they would need for the future, in the future healthcare force, specifically also thinking about digital skills. And here, what could be what are the conditions to have more success in with our health investments? How can we ensure that our health funding is used in a most effective way? For this, we encourage very strongly the member states, the regions to invest a lot in strategic policy framework for the health. And this is infrastructure mapping, a mapping of all health needs, the services that are available, the medical staff that is available, all the infrastructure that is available, in order to analyze gaps and ensure that the investments that are being done are tackling exactly these identified gaps in the healthcare systems. At the same time, these national and regional strategic policy frameworks, so these are just regional health strategies, they should include also measures for the affordability and accessibility of health and long-term care services, and they should promote community-based services, including also prevention and support to primary health care. So just in conclusion, and because I'm also interested to hear the discussion after, The guiding principle of the EU health investments is to improve accessibility, effectiveness, and resilience of the health systems. It is very focused on the transformational changes that could be achieved. So this is what the EU is trying to work on together with the member states, how to reflect on building more flexible, more resilient healthcare systems that could be able to address future health crises and pandemics. For this one, it is also very important that the integration of this health investment should be in the broader health reform. So for which we need good plans, we need strategies which are long-term, which are based on mappings, on needs assessment, and that we do not forget on this way investment in people, networking, of training, of working in their infrastructure. That a study on the COVID effects in the outermost regions. So here on these links, you'll be able to find the whole study and some fact sheets for the Azore Islands, the Canary Islands, and Madeira. Thank you very much.
Thank you so much, Boryana, for its presentation and the fact sheets information that are available. We are now wrapping up very fast for the dinner, the lunchtime, which is already starting in a few minutes. But I would like to do just a final, try to make a conclusion here on short intervention, specifically because we have here João Santos that can have also perspective on the outcomes assessment for these programs that the European Union is funding, and how health data can help community services development. So that will be perhaps starting with you, Steve. Health data for community services, and then João comment a little bit the outcomes for Boryana also to comment on that.
Information is power. It allows people to make decisions, and I think that's really crucial. And I think as Boryana was saying, as they're putting more emphasis on primary healthcare, it's educating people to understand what their own data is telling them about themselves. So I think producing information for people is important, but also helping people to understand those information and then help them to monitor it over time, so that we put less stress on the health facilities, on health systems. And I think that's really that's crucial. And I think that's crucial for data generally, is helping people to use the information. So transparency is key. From a digital perspective, what that means, I think the future, what it holds is, if in my phone, I should be able to access my own health records. So irrespective of where I am, if I go to a different doctor, I can carry my own health information with me. So I should be familiar with my own health information, and I should be able to share it with the doctor if I want to. And if I don't want to, that's my choice. And I think that's really where we're going. The big challenges then is how do we store that information securely? So do I carry that information with me, or is it in the cloud somewhere, and then I can give the doctor access, I can give permission? These are things that need to be thought through. But I mean, I think that is where we're going. So instead of individual health facilities holding pieces of my information, we may switch the model, and it may become more customer-centric or more patient-centric, and that we actually have access to all of our own information. And I think that's the future, I think.
Thank you very much. João, you want to intervene here also on the outcomes, and then Boryana to also answer this?
I think that in terms of evaluating, So thanks. I think that in terms of evaluating programs and plans overall in terms of health systems, again, it comes to a point when we have to ask ourselves what kind of information can we rely on. So what kind of health outcomes can we rely on? And as Steve mentioned, there are so many, there's so much information, and a lot of that is noise. A lot of that cannot be reused, but there is still a lot that can be indeed reused. For instance, the European Health Interview Survey, we can start working more and more. We have, for instance, a European Burden of Disease Network working specifically on producing burden of disease estimates and other kind of things that are being produced right now in terms of the very wide spectrum of data. But at the end, I think that we need to do some steps, and one of these steps is to give more access, for instance, for the academic institutions to work more on this kind of health data, because we talk a lot of knowledge transfer between the academics and institutions, but at the end, if we don't have information, we don't have knowledge. So we need to bridge and to close this gap between academics and governance and health institutions. And on the other page, I think and I hope that the European health data space can really push up things in order to have more data sharing, but also to promote not only in terms of national systems, but also widely in all kind of health institutions, a specific way of thinking that actually Steve mentioned, that is data governance. We need data governance, including all the aspects of data governance, including, of course, as we mentioned before, data quality, and only with that we can finally address health outcomes and address and assess interventions in health systems.
Thank you as well.
Thanks.
And Boryana, can you comment on this health data governance needs? Is this reflected in the programs the EU is funding? And
indeed, I mean, a lot of infrastructure is necessary for it. So we invest in the infrastructure, in this collaboration, in this smart collaboration, basically to bring the regions to work together in the European health data space, which is this new proposal of the EU to bring the different systems closer together. And it is in pilot phase, so not all member states will be participating. But what is important is that data and digitalization has very strong impact on the territorial inequalities. Imagine if you, in your member state, in your region, on your island, cannot access specific treatment, but you can take your data and go to the closest place, even in another member state, to be treated with the highest quality of health services. That would change so much the way we think about it, and it would reduce at the end the health outcomes. So here we reflected very much from the perspective of how this could enable more people to have access to healthcare, a more affordable one, potentially also without having to leave their homes. It is again in the remit of the member states to design these programs in their regional development plans, in their regional programs. And here is my urge to the people who are in the room to be active stakeholders in this policy, government funding for mention.
Okay, thank you so much, Boryana. I think we got a good grasp of your last talk, because we had some communication issues here, but the full of the message passed, and thank you so much. A round of applause for this panel, if you may, and I think we are now going to close the session. Thank you so much.